Welcome to the Radonc Smart Review GI Cancer Series. Today we're diving into Pancreas Part 3. It's really a masterclass focusing on locally advanced pancreatic cancer, LAPC, and the role of SBRT. This follows our previous discussions on resectable and borderline cases, where surgery is, the main goal. But today it's a different scenario, equally tough, and honestly something we see all the time.
That's exactly right. We're shifting focus now to those patients whose tumors are, well, too involved with major blood vessels for upfront surgery. Locally advanced, unresectable disease. But, and this is key, no distant metastases at diagnosis.
Right. So the whole goal changes, doesn't it?
Completely. We move from aiming for a surgical cure to focusing on long-term control, extending life, maintaining quality of life. And this is where radiation, particularly SBRT, has really evolved and shown some pretty remarkable progress. So we'll dig into the older data on conventional chemoradiation, explain why we push for these ablative SBRT doses now, and tackle that big debate, how do we define the target volume?
Sounds great. Let's start with the basics. You get a new LAPC patient, good performance status. What's the absolute first move before any radiation comes into play?
Okay, the first step, non-negotiable really, is induction chemotherapy.
Always chemo first.
Always. There are a couple of critical reasons for this. First, we have to treat potential micrometastatic disease systemically. Pancreatic cancer, as you know, loves to spread early, even if we can't see it on scans yet, so chemo hits that first.
Okay. Systemic treatment up front. Makes sense. What's the other reason?
The second reason is it acts like a biological stress test almost. It helps us identify patients whose disease is just really aggressive systemically. If someone progresses quickly on good chemo, throwing intensive local therapy like radiation at them probably isn't going to help their overall outcome much. Their prognosis is unfortunately driven by the systemic spread.
That's a great way to put it, a biological stress test. It selects the right patients for local therapy.
Exactly. Think of induction chemotherapy like a pre-screening test. Before we commit to definitive local therapy, like SBRT, we need to see how the disease behaves systemically. And frankly, if the patient can tolerate intensive treatment, it's like sending out feelers before making a big investment.
Got it. So what are the go-to chemo regimens here, and how long does this induction phase typically last?
The main players are the aggressive multi-agent regimens. Usually it's either MFOL-FIRI-RNOX or the combination of gemcitabine plus nab-paclitaxel.
The heavy hitters.
Right. FOL-FIRI-RNOX is very potent, maybe slightly more toxic. Gem-nab-paclitaxel is another strong option, sometimes a bit better tolerated. And the duration is usually substantial, typically 4 to 6 months.
4 to 6 months. Okay. That gives enough time to really see the response in biology.
Precisely. It lets the chemo work systemically and helps us gauge that tumor aggressiveness and patient tolerance before we decide on the next step.
So let's say the patient gets through those 4 to 6 months of induction chemo. Scan shows stable disease, no progression, no new mets. What's the big question then? More chemo, or is it time for radiation?
That's the critical decision point. And for a long time, there wasn't a clear answer. Do we consolidate with radiation or just continue systemic therapy?
Right, that was good debate.
Exactly. And this is where the LAPO7 trial becomes so important. It was designed specifically to answer this question.
Okay, tell us about LAPO7.
It was published in JAMA back in 2016. They took LAPC patients who were stable after 4 months of induction chemo, specifically gemcitabine in this trial. Then they randomized them. One group got 2 more months of just gemcitabine. The other group got consolidative chemoradiation 54 gray of conventional radiation with concurrent capecitabine.
54 gray, standard dose back then, and the key endpoint.
Overall survival, that was the primary question. Does adding this conventional chemoradiation improve survival?
And the answer was?
The answer was pretty clear, and maybe a bit surprising at the time. No, it did not improve overall survival. Median overall survival was basically the same in both arms, around 16 months.
16 months, either way.
Yeah.
So adding the radiation didn't make patients live longer overall.
Correct. That was a major finding. It really challenged the routine use of conventional dose radiation purely for an OS benefit in this setting.
So if OS wasn't improved, what did radiation achieve in LAPO7? Did it offer any benefit?
It did. While OS wasn't better, the radiation significantly improved local disease control. The rate of local progression, meaning the tumor growing back in the pancreas area, was much lower in the chemoradiation arm. It was 32% versus 46% in the chemo-only arm.
Okay, so a definite improvement in keeping the tumor controlled locally.
Yes, a significant reduction in local failure. And that translated into a longer treatment-free interval for patients as well. They had more time off therapy before needing something else.
Which is a big quality of life benefit.
Absolutely. So the key takeaway, our clinical pearl number one here. The LAPO7 trial showed conventional chemoradiation improved local control, but not overall survival for LAPC after induction chemo. This really ended the routine use of that specific approach just for survival, and it pushed the field to think, well, what if we used higher doses?
Right. If 54 gray isn't enough to impact survival, maybe we need a much bigger punch locally, which leads us directly to SBRT, stereotactic body radiation therapy.
Exactly. The thinking became, can we deliver a truly ablative dose with SBRT? Can we aim for actual tumor eradication locally, not just control?
Define ablative dose for us in this context. What's the target we're aiming for?
The common benchmark we use, especially assuming an alpha-beta ratio of 10 for tumors, is a biologically effective dose, or BED, of 100 gray or more. BED 10 greater than 100 gray. That's generally considered the threshold for achieving high rates of tumor ablation.
And is there evidence supporting that 100 gray threshold?
Yes, there is. A key meta-analysis by Mahadevan looked at SBRT for colorectal liver metastases, another challenging site. They found that achieving a BED 10 over 100 gray was necessary to get local control rates above 90%.
Okay, so data from other sites supports hitting that BED target.
Right. Now, pancreas radiobiology might be slightly different, but it gives a very strong rationale for aiming high. And a very common SBRT regimen that hits this mark perfectly is 50 gray in 5 fraction.
50 and 5. Let's calculate that. 10 gray per fraction. Yeah, using the BED formula with alpha beta of 10, that comes out to exactly 100 gray BED 10.
Precisely. It's a widely adopted ablative regimen for pancreas SBRT.
So the theory and the radiobiology point towards needing these high doses like 50 and 5. Does this actually work in practice for pancreatic cancer? And crucially, is it safe?
That's the critical question. And the exciting answer from recent data is yes, it does seem to work, and yes, it can be done safely with modern techniques. The SMART trial is really important here. It was a phase 2 study published in 2023.
The SMART trial, what did they do?
They use MRI-guided SBRT, which gives amazing real-time visualization to deliver that exact dose, 50 gray, in 5 fractions. The patients had either borderline resectable or locally advanced disease.
And the results?
Really impressive. The 2-year local control rate was 83%.
83%. That's fantastic for LAPC.
It really is. And the 2-year overall survival was 53%, which is also very encouraging compared to historical controls. But here's the kicker, especially regarding safety.
The toxicity.
Exactly.
Yeah.
The rate of grade 3 or higher gastrointestinal toxicity directly related to the SMART protocol was 0%.
0%.
Yeah.
With 50 grays in 5 fractions to the pancreas. That's incredible.
Oh. It truly is. It's a testament to the precision of MRI guidance and meticulous planning. It shows that these ablative doses can be delivered safely. So, clinical pearl number 2. Ablative SBRT doses, like 50 grays in 5 fractions, offer excellent local control, and modern techniques like MRI guidance make them very safe, minimizing severe GI toxicity.
Okay, that's really compelling evidence for using ablative SBRT doses. But now we hit the big controversy, right? What exactly do we target with that 50 gray?
Yes, this is probably the most debated topic in pancreas SBRT right now. What is the correct target volume? Early trials often just targeted the GTV, the gross tumor volume you see on the scan.
Just the visible tumor. But is that enough?
Well, the patterns of failure data strongly suggest it might not be. There was a pivotal paper by Zhu and colleagues in the Red Journal in 2019. They looked carefully at where tumors recurred after SBRT.
And what did they find? Where were the recurrences happening?
Over 90% of the local regional recurrences weren't actually in the original GTV. They were happening in a very predictable area. It was the paravascular space, basically the tissue surrounding the celiac axis and the superior mesenteric artery. This region is now often called the triangle volume.
The triangle volume. So failures were happening around the major vessels.
Exactly. The implication is huge. It strongly suggests microscopic spread along nerves' perineural invasion and along the vessel's paravascular invasion. These are pathways pancreatic cancer uses to spread that we often can't see on imaging.
So just treating the visible GTV misses this microscopic spread in the triangle volume.
Precisely. A GTV-only SPRT approach is likely to fail in that region because you're not treating those unseen microscopic extensions. And this likely explains why some earlier trials, like that Alliance A021501 SPRT arm we mentioned before, had somewhat disappointing results. They probably didn't adequately cover this area.
That makes perfect sense. You have to target the likely pathways of spread, too. So what's the solution, then? How are we addressing this?
The field is rapidly moving towards including this high-risk perovascular area. We call it elective coverage, sometimes loosely termed ENI, elective nodal irradiation, though it's more about perineural and perovascular pathways here. There's actually a new NRG consensus contouring atlas for pancreas SBRT, led by Sanford, published this year, 2024. It explicitly endorses contouring a low-dose elective CTV, clinical target volume, to cover these pathways, this triangle volume.
Okay, so we're formally recommending treating this area now. How is that typically done dose-wise?
The common approach now is a simultaneous integrated boost, or SIB. You deliver the high ablative dose, like 50 gray in 5 fractions to the GTV, and simultaneously in the same plan, you deliver a lower subablative dose, maybe 25 to 35 gray in 5 fractions to that elective CTV, the triangle volume.
So hitting the main tumor hard and covering the high-risk surrounding area with a moderate dose.
Exactly. You're trying to sterilize the gross disease and also eradicate that likely microscopic spread.
Great. And a mnemonic for our residents. To remember that critical recurrence zone, think of the zoo triangle, Z for zone, H for high risk, and U for unseen spread. Don't forget to cover the zoo triangle.
Okay, we focused heavily on locally advanced disease. What about the less common scenario, but one we do see? Patients presenting with limited metastatic disease, oligometastatic disease. Is there a role for SBRT there?
This is another really exciting area, though again, it's for a very highly selected group of patients. The EXTEND trial provides the first randomized evidence here. It was just published in JCO in 2024.
EXTEND, what did they look at?
They took patients with 5 or fewer pancreatic cancer metastases, oligometastatic disease, who had already completed their initial systemic therapy and hadn't progressed rapidly. They randomized them to either continue standard systemic therapy alone or to receive metastasis-directed therapy to all sites of disease, which was SBRT, in 94% of cases, followed by more systemic therapy. So hitting all the known spots with SBRT versus chemo alone, what happened?
The results were striking. Adding the consolidative SBRT made a huge difference in delaying progression. Median progression-free survival, PFS, jumped dramatically. It went from just 2.5 months with chemo alone up to 10.3 months with the addition of SBRT.
Wow, from 2.5 to 10.3 months PFS. That's a massive improvement.
It really is. It suggests that even though pancreatic cancer is systemic, aggressively treating all visible disease sites with SBRT can significantly delay the time until the cancer progresses further in these select patients.
So that brings us to clinical pearl number 3. For highly selected patients with low-volume oligometastatic pancreatic cancer, like 5 or fewer mets, using SBRT to ablate all sites can significantly improve progression-free survival, a potential game changer for this specific subgroup.
Exactly. It's important data, though we need to remember it's phase 2 and for a very specific population, but definitely practice-changing potential there.
Okay, let's try to tie this all together with a quick case. How about this? You have a 65-year-old patient, newly diagnosed LAPC. Scans show extensive superior mesenteric artery encasement, definitely unresectable, no distant mets on CT or PET scan. They just finished 6 months of FOLFIRI, RANOX, and their restaging MRI shows stable disease, good performance status. Based on everything we've discussed, what's your thinking for the next step and what are the critical parts of your treatment plan?
Okay, great case. Classic scenario. So, P.S. Stable after 6 months of tough chemo, that's key. This patient has shown they can tolerate treatment and don't have explosive systemic disease. So based on LAPO7 showing local control benefit and SMART showing efficacy and safety of ablative doses, consolidative radiation is definitely indicated. And specifically, SBRT is the preferred approach here.
SBRT it is. Now walk us through the key planning points for this specific patient. Dose, target, OARs.
All right. Dose, aim for ablative. 50 gray and 5 fractions to the GTV is my standard, aiming for that BED of 100. Contouring. This is critical. Given the SMA encasement, I absolutely need to include coverage of the triangle volume. So, I'd plan an SIB 50 gray and 5 to the GTV, and simultaneously, maybe 30 gray and 5, or perhaps 25 and 5, to an elective CTV covering that perivascular region, guided by the NRG Atlas.
Okay, 50 to the GTV, 25 or 30 to the CTV triangle volume. What about organs at risk?
OARs are paramount. The duodenum is number one. It's the main dose-limiting structure. I'd be strictly adhering to the Murphy constraints, especially keeping the volume of duodenum receiving 15 gray to less than 9.1 cc. We absolutely have to respect that constraint to minimize the risk of late severe toxicity like bleeding or perforation.
Makes sense. The goal is long-term local control, potentially longer treatment-free time, but safety first, especially with the duodenum.
Precisely. It requires meticulous technique.
And you mentioned techniques like MRI guidance earlier. Just reiterate why those technical aspects are so vital for delivering this safely.
They're absolutely essential. Modern imaging, like MRI guidance or advanced cone beam CT on Linacs, gives us incredible soft tissue visualization. We can see the tumor and the duodenum much more clearly than with older techniques. It also allows for managing motion breathing, bowel gas.
Real-time tracking or gating.
Exactly. We can adapt plan daily if needed. And the meticulous contouring we discussed, defining the GTV, that crucial CTV for the triangle volume, and painstakingly drawing the OIRS, like the duodenum, it all relies on good imaging and anatomical knowledge. It's this combination of precise imaging, motion management, and careful planning that lets us deliver those high ablative doses while minimizing the risk, achieving results like the 0% grade 3 plus toxicity in SMRT.
All right, excellent. Let's shift gears and hit the board blitz. Ready? I'll give you a board-style question. Listeners, you can pause and think about your answer. Okay, case one. The LAPC study of locally advanced pancreatic cancer demonstrated that what? A. Chemoradiation improved overall survival. B. Chemoradiation improved local progression. C. The addition of erlotinib to gemcitabine improved overall survival. D. The addition of erlotinib to gemcitabine improved local progression. What's the answer?
The answer is BLAPO7 was negative for its primary endpoint, overall survival, but it clearly showed a statistically significant improvement in local control, reducing local progression. Options C and D relate to erlotinib, which wasn't the focus of the primary LAPO7 randomization comparing chemo versus chemorti.
Correct. Case 2. For pancreas SBRT, which regimen achieves a biologic effective dose, or BED, for tumor closest to 100 gray, assuming an alpha beta of 10, A 6 gray times 5 fractions, B 8 gray times 5 fractions, C 10 gray times 5 fractions, D 12 gray times 5 fractions.
Okay, BED calculation time. Alpha beta of 10. The answer is C, 10 gray times 5 fractions. BED equals 1 and 1 plus alpha beta, so 510, 1 plus 1010 equals 50, 1 plus 1 equals 100 gray. That's the ablative benchmark.
Perfect. Last one, case 3. You are planning single fraction SBRT to a pancreatic lesion to a dose of 25 gray. According to the data from Murphy and colleagues, which organ is the primary dose-limiting structure? A. Common bile duct. B. Duodenum. C. Liver. D. Kidney.
For single-fraction pancreas SBRT, especially at a high dose like 25 gray, the answer is definitely B, the duodenum. The Murphy data specifically highlighted duodenal toxicity as the limiting factor and gave us those crucial volume constraints like V15, 9.1 cc to minimize severe late effects.
Excellent. 3 for 3. Now, looking beyond the core data, what are some lingering controversies or exciting future directions in LAPC treatment?
Well, that target volume issue, even with the NRG Atlas, is still being refined. What's the optimal dose to the triangle volume? Are the margins right? How do we best balance control versus toxicity there? That's ongoing research.
Refining the CTV dose and margins. What else?
The oligometastatic SBRT story is still unfolding. EXT-ND was phase 2. We're waiting for larger trials to confirm the OS benefit and really nail down patient selection. It's promising, but needs more data.
Right, confirming the extent findings.
And then there's the whole integration with newer systemic therapies. How do we best combine SBRT with immunotherapy, for example? Can we leverage the abscopal effect? Lots of trials looking at novel combinations. The field is moving fast.
Absolutely. Okay, let's summarize the key takeaways from today's masterclass on LAPC and SBRT.
All right. First, for LAPC, always start with induction chemotherapy. It's essential for patient selection and treating micromets. Second, LAPO7 taught us conventional chemoradiation improves local control but not OS, shifting the focus. Third, this led to SBRT, where ablative doses like 50 grays and 5 fractions offer excellent local control and can be delivered safely with modern techniques.
And fourth, remember, the target volume debate is critical. Evidence strongly supports covering the triangle volume, the zoo triangle, likely with a lower simultaneous dose, moving beyond GTV-only treatment. Finally, for that select group with oligometastatic disease, EXTND gives strong support for aggressive, consolidative SBRT to delay progression. So here's a final thought to ponder. As our technology gets better imaging, adaptive planning, AI, maybe of it, how might we push precision even further in LAPC? Could we one day truly visualize and target those microscopic extensions individually, or tailor the treatment based on a tumor's unique biology and spread patterns? It's exciting to think about where we're headed. That wraps up another episode of the Radonc Smart Review GI Cancer series.
Yeah, over these last 3 episodes, we've really covered the waterfront for localized pancreatic cancer management.
We have. In our final episode on pancreas, part 4, we're going to synthesize everything. We'll review the ASCO and ASTRO guidelines, get into the nitty-gritty of conventional and SBRT planning techniques, practical tips for you, and wrap up with a final case-based review to put it all together. Remember to check out the practice oral boards at radoncSmartLearn.com and subscribe to Radon Smart Review so you don't miss part 4. Thanks for tuning in.